Services, as a partner agency, want to welcome you to our Prevention Summit, Community and Parents that Make a Difference. I'm really a firm believer that it's not just the clinical work that we do every day, but it's also the environment where we work, where we go to school, and where we play that makes a difference too. So the work that we do in the clinic offices and the work we do in the community all come together to make a healthy family. So we want to welcome you today. We're ready to start the first session this morning. And if there are anyone that wants to go to the first session for the parent track, that's in room 326. But we'll go ahead and get started, and I'll be introducing your first speaker. And one thing I wanted to mention to you about the CEUs, in your packets, there are CEU evaluation forms for each speaker today. So if you would complete those at the end of each session, and then at the end, you can turn them back into the registration desk, and you'll be able to get your certificates today. So there are folks out there at the desk that will be helping you with that as well. So it will take a brief few minutes between each speaker. So if you need to take a break to go to the restrooms or whatever, that'll be fine too. And then at the very end, for those folks that are registered, we will have a box lunch. So that'll be something that you can do at the end of our sessions today and enjoy the afternoon. So let me go ahead and introduce our first speaker. I want to introduce Dr. Kristen Savicki. She is a psychologist with the Adult, Child, and Family Division of Louisiana's Office of Behavioral Health, and it's within the Department of Health and Hospitals. She conducts analysis and quality improvement activities related to behavioral health services for youth to support increased alignment with best practices and improved system design. Her content expertise includes evidence-based practices and system of care approaches for youth. She facilitates Louisiana's Attention Deficit Hyperactivity Disorder Task Force, an initiative of the Department of Health and Hospitals to develop a comprehensive public health-oriented policy response to Louisiana's high rates of ADHD diagnosis and prescribing. So without further ado, I want to present Dr. Savicki, who's going to talk to you about the Louisiana ADHD Initiative. And there will be an opportunity for questions at the end.
All right, everybody, can you hear me okay? I have bad luck with microphones, so let's just cross our fingers that I don't blow out people's eardrums. Thanks, everyone. Again, my name is Kristen Savicki. I work with the Office of Behavioral Health. And this is a really nice opportunity for me. I work on sort of statewide approaches to ADHD, but it's really nice to get a chance to talk about this work with my own community. I live in EBR, my kids go to EBR school, so it's really nice to be able to discuss this with all of you today. So first, let me just ask, who do we have in the room? Raise your hand if you are a licensed social worker or counselor. Ooh, all right. Good crowd. Let me know, raise your hand if you work in the school system. Great. What about independent practice? Agencies, community mental health agencies, right? Anyone work in integrated healthcare settings like pediatric practices, hospitals, anything like that? Okay, great. And what about, how many of you are parents? Who's got my little kids less than school age? Good, good, good. All right, so I'm with you right there. How many folks, school age kids? Great. And how many of you have gotten your children to survive to the teenage years? Excellent. I will be talking to you after the session for some advice. Okay. Thanks, everybody. So I'm going to talk to you about the initiative that we've been working on for the past couple of years, our ADHD initiative. So let me give you a little bit of sort of orientation to what I'll be talking about. I'll talk to you about the statewide data that we've been looking at and what it tells us about how ADHD is diagnosed and treated in our state. This is the point, by the way, where you realize that I'm not a good act to follow Chief Jeff. I'm be talking to you about data, so hopefully we can all stay awake here on that Saturday morning. We're going to identify the goals that we have for ADHD diagnosis and treatment, and based on best practices and national guidelines, and identify interventions that we can use on a statewide level and at all different modalities to increase the use of best practices. And that's across systems, across the healthcare system, behavioral health, and education. And I'll touch on all of those aspects. And then I really want to talk about the key roles that all of you in this room can play as behavioral health specialists in this effort. So now I'll give you a little bit of background about how we started at the Department of Health, how we started working on this initiative. So there was a Senate concurrent resolution in 2014 that requested for us to look at the high rates of ADHD diagnosis and prescribing in our state, and really look at what is the most effective way to make sure that we have effective utilization of ADHD medication. Our then Secretary, Kathy Kleber, convened a departmental task force to take a look at this data and research. And we convened that group and really worked on doing our research, really kind of putting together the pieces. We convened a symposium at the end of 2014 and welcomed stakeholders from education, healthcare, behavioral health. I don't know if anybody in this room was at that ADHD symposium about a year and a half ago. And then following that symposium, we really used the information that we got from stakeholders and all the research that we've done. We used a lot of great help and technical support from the Centers for Disease Control, who have a big initiative going on around ADHD. They've been very, very helpful to us. We submitted our report to the legislature as requested in February of 2015, and since then, we've really been looking at trying to implement the recommendations that came out of all of that research and work. So that's where we are now. All right, so now, bear with me. Now let me take you through some of the data that caught our attention when we started this initiative, some of the data that made us think, we gotta get a handle on this, we gotta understand this a little bit better. So first of all, this, by the way, I have to give credit, this is the CDC slides which they have let me use. This really just shows you nationwide trends in the diagnosis of ADHD over time. And you see at the beginning of the graph, we have 1998, this goes all the way up to 2014. It's just, and each data point on this slide is a different study, a different group conducting a study of the prevalence of ADHD diagnosis in kids. And as you can see, it's just been going up steadily over time for the last couple of decades. So then there's some interesting things. There's not just a rise over time, there's also some very interesting regional differences, which cause us to sort of look a little closer and think a little more about this. So the nationwide increases don't tell the whole story. Oh, what did I just do? Hold on, guys. There we go. Apologies. All right. It's all right, we're just going to go with it. So there's regional differences. As you can look on this map, the darker colors represent a higher percentage of kids in that state with an ADHD diagnosis. So this is interesting, right? There's not really a sort of clinical reason you would think that more kids in Louisiana would have ADHD versus, so you see that sort of lightish state over there, that's Nevada. So why do kids in Nevada have less ADHD than kids in Louisiana? It causes us to sort of wonder, well, what's going on here? And as you can see, the rate of kids with ADHD in Louisiana is 13%. The national average is 8%. So we're pretty high. In fact, I think, although I can't scroll down in my notes right here to find out, but I think we're the third. So this next map shows you not ADHD diagnosis, but medication treatment. So this shows you what percentage of those kids with ADHD who are diagnosed with ADHD are being treated with medication at that time. And again, regional differences here. So why are kids in different states getting different, sort of amounts of getting prescribed medication at a different rate? And again, you can see, our Western states, some of them, it's less than 65% of those kids with ADHD are getting medication. And then there's a lot of other states with those darker orange colors that are getting, a large percentage of them are getting ADHD medication. And the national average is 69%. We in Louisiana are here at 78%. 78% of our kids with ADHD are being treated with medication. We are #1 in the nation, or at least as of the data from a couple years ago. We're #1 in the nation in terms of our use of medication to treat ADHD. So this caught our attention. I can tell it's kind of catching the attention of some folks in the room as well. This caught our attention and made us wonder, what's going on? And is this okay? Is this appropriate? Are we doing the right thing for our kids? So that caught our attention. We really wanted to take a look. So then we started to dig deeper into data that we could look at here in Louisiana. We took so all the stuff you've seen up to now is data that the CDC has gathered, nationwide data, and been able to drill down and show us what's going on in Louisiana. We at the Department of Health looked at Medicaid data because that's the data that we have the best access to and that we have some influence over what's going on within the Medicaid system. Which, by the way, it is a pretty rich source of data given that over 50% of our kids in Louisiana have Medicaid insurance. So we have a lot of kids that we can look at and really look at what's going on within that system. In fact, if you look at kids, the data that we're about to look at, it represents children between the ages of 4 and 18. And in the year of data that we're looking at, 2013, 64% of those kids had Medicaid funding. So we got a lot of kids we're looking at here. So this is our own Louisiana Medicaid data. So what I'm going to just sort of highlight for you here is, first of all, each year of age for a kid, that's what you see across the bottom, from 0 up to age 18. Each year has 3 different bars, which represent 3 different years, 2010, 2011, 2012. So as you can see, the rates increase every year. So that's consistent with national trends. Here in Louisiana, just like in national trends, we're seeing the rate of diagnosis, this is the rate of kids being prescribed medication, that's been increasing every year. Also just want to show sort of the age trends for the prescribing medication to kids. As you can see, it starts going up, as early as age, 2 and 3 starts to rise. The most kids receiving ADHD medication are around age 8 or 9. That's the peak. The highest percentage of kids receiving medication is at ages 8 or 9. And then it starts to fall a little bit through early adolescence, late childhood, early adolescence, all the way through. So to understand those age patterns, I just want to bring you some information, and again, this is back to CDC data, some information on how ADHD works over the years, and many of you may be familiar with this already. So ADHD has kind of 2 different components, right? It has the inattentive component and then the hyperactive component. Some kids have one or the other, a lot of kids have both. So we really talk about the inattentive symptoms and then the hyperactive and impulsive symptoms. And those 2 sets of symptoms operate differently as kids age. So the blue line here are the hyperactive symptoms. And as you can see, they're highest when the kids are youngest. And then they start decreasing steadily. Brains mature, kids mature, they start being able to get a better handle on that hyperactivity and impulsivity as they age. Now the inattentive symptoms is that white line. Those stay pretty steady. That's a little bit more hardwired, and it doesn't change that much over time. So if we think about that in relationship to this slide again, what this says to me, that the age-related patterns of prescribing, you can see that they sort of fall over time. What that tells me is that those hyperactivity symptoms are really the ones that are driving a lot of the medication treatment. That those are the symptoms that are causing kids a lot of distress, are causing parents and teachers a lot of distress. That may be something that's driving a lot of those that need for medication prescription, and maybe not so much the inattention, because inattention is not going down over time. So there's discussion, amongst researchers on ADHD that ADHD medication is both over and underused. That it could potentially be overused with kids with more hyperactivity, who tend to be younger kids, also tend to be more male. So we have those sort of younger boys with the hyperactivity symptoms that may be getting more medication, or more of them may be getting medication than is really appropriate. But then those older kids with the more inattentive symptoms, oftentimes those are girls, they may be getting sort of an underuse or under-prescription of medication because they may be, they're not behavioral problems, they might be kind of flying under the radar, and they're still struggling in school because those inattentive symptoms don't go away, but those struggles are not getting noticed as much and are not getting treated. So we have sort of both of those sides. Okay, now this is a tricky one to look at, so let me walk you through it. So we tried to just slice and dice all of this data by age. So what you're looking at here is a whole bunch of little graphs. Each little graph represents all the kids of a certain age. So we start with 4-year-olds up at the top, 5-year-olds, 6-year-olds, 7-year-olds, and sort of keep going all the way up to 18-year-olds at the bottom. And for each of those little graphs, so let's take the 7-year-olds here on the top right corner. Each of the, all of those kids who are 7 years old, when we looked at this data, we sliced them up according to their birth month. So we've got January, February, March, a little bar for each month going across that graph. Now, there's not really any reason that a kid in January would have more ADHD, more likely to be ADHD than a kid in August, right? So we really expect those bars to be level across, but that's not what we see. Interestingly enough, starting at about age 6, we see this interesting little spike towards the end of the summer, those birth months, and a little drop off in October. So, and we see that in the little red arrow on each graph shows you where that little drop off is happening. So in each year, we see that there's more kids who are born in August and September who are being prescribed medication for ADHD, and fewer kids born in October who are being prescribed medication for ADHD. As we know, the kindergarten cutoff date in Louisiana is you have to be 5 years old, you have to be a particular age by September 30th. So what that tells us is that in any given classroom, in that 7-year-old's second grade classroom, the kids born in August and September are the youngest kids in the classroom. And the kids born in October are the oldest kids in the classroom. And so those August and September birthday kids, they're almost a year younger than those October birthday kids. So that's really suggestive to us that those kids, those August and September birthday kids, they might look ADHD, right? They might really look and have a hard time fitting into that classroom setting. And it might be because they have ADHD, and it might be just because they're younger. And so they developmentally haven't gotten there to have the skills to regulate their behavior, to pay attention. They haven't gotten there the same way those kids who were born in October have. So this we found very interesting, and I can see some nodding across the room. Okay, so all right, we sliced it up by age. Then we also wanted to look at those prescriptions. Who's doing those prescriptions? Where are they coming from? You know, what's happening there? So we looked at the first time a kid gets prescribed medication for ADHD, because we figured that's a good, point to figure out when did it happen, was it done appropriately, what's going on. So we sliced it up by who did those prescriptions. And you can see we've got 45% of those prescriptions came from pediatricians and 18% from family practitioners. So if you add that up, okay, I can't add up like 60, it is in my notes, 63%. 63% of those first-time prescriptions are coming from primary care physicians, rather than, psychiatrists or, behavioral health specialists. So it really is our primary care doctors that are providing those first-time prescriptions for kids. We also want to look at the age of first prescription. The average age at first prescription, here, this is Medicaid data here in Louisiana, is 6.7. So we've got 6 and 7-year-olds who are kids generally at about 6 or 7 years of age. That's when they're getting those first prescriptions for ADHD medications. So that's first and second grade. Okay, all right, let me orient this one. This is an interesting map that our very competent data people came up with, and so I will skip over some of the intricacies of how they came up with this. But this is essentially looking at regional differences just within Louisiana. So we know the nationwide state and regional differences, but within Louisiana, we wanted to look at, are there differences across different parishes and regions in the rates of ADHD medication use? And what our fancy data people did with this map is they took the rates of ADHD prescription and they controlled for age, race, and gender, because those 3 factors do tend to correlate. We've got more More boys are diagnosed with ADHD. Age obviously plays a role. White and African American children have higher rates of ADHD versus Latino children. So they controlled for all those factors based on different demographic mix in the state. And so after controlling for those factors, you wouldn't think that you would see differences in rates of ADHD prescriptions across the state, but we do. So red in this slide represents more ADHD prescriptions than you might expect based on the demographic mix, and blue represents less. So we just sort of have this interesting thing across the south of the state, and then the north is a little different. So we don't honestly have a great explanation for this, but it tells us, and a lot of the data that I've presented so far suggests us that there's something a little bit man-made about some of this, right? This might not have to do entirely with kids' clinical needs or presentations. This might have to do with something going on with our healthcare system or access to services. It might have something to do with differences in prescribing practices in different places. It could be about differences in sort of educational systems and their approaches. And we can't really pinpoint exactly what it is, but it does tell us there's a lot of things we need to look at to make sure that kids are only getting diagnosed and treated with medication when they really need to be and when that's really the best thing for them. So, takeaways from all of this data, and I'll move on to the goals and stuff in a minute. But takeaways, first of all, rates are going up of both diagnosis and treatment, both nationwide and also in Louisiana. In Louisiana, we diagnose and treat with medication kids more than other places. The age patterns and prescription rates suggest that medication might be linked most closely to those hyperactivity symptoms, and they might also be related to that kid's developmental fit based on their age within a classroom. And those first prescriptions are being written by primary care doctors at a pretty early age, at 6 and 7 years old. So that's what we can take from this data. Now, what don't we know? And I really want to make this point because this is important. High rates of diagnosis of medication are a red flag, right? It makes us really sit up and take notice and want to think about, are we doing this right? What's working, what's not? But they don't alone tell us that we have a problem. And we don't know that these diagnoses of kids are inaccurate. And we don't know, just based on the data I've given you so far, we don't know if the medications are being used incorrectly. So we don't want to jump on an idea that our goal is fewer diagnoses and fewer medication, because we don't know that for sure. We need to do a lot more work to define with some precision what we want to see, because we don't necessarily want to drive down rates of diagnosis and medication, because that runs a risk of just restricting treatment for kids and restricting support for families. And we don't want to do that. So we want to think about, okay, what do we need to see? What data do we need? What measures do we need to know that this is being done right, rather than just trying to kind of clamp down? So that's been a lot of the effort that we've done with the ADHD task force and our initiative, is we really need to define our goals. We can't define our goals as let's clamp down on medication, because we don't know if that's just taken away the one thing that kid needs in order to function well. We really want to look at what are our actual goals. How can we know that we're getting kids the help and support that they need? So to define the goals, first of all, we have to define the problem. And again, we don't want to define the problem as we got too many diagnoses and too many medications. We really want to define the problem as rates of ADHD diagnosis and treatment that are high for the wrong reasons. This is a very technical term, right? The wrong reasons. But that's sort of how we've been thinking about it. So what are the wrong reasons? What would be sort of the wrong reason to diagnose a kid with ADHD and treat them with medication? And there's a number of potential sort of wrong reasons. So one wrong reason is overdiagnosis. So overdiagnosis is when a behavior is sort of labeled as clinical or disordered, and really it's just sort of part of the continuum of behavior, and it's somewhere sort of in the range of typical. So this little arrow here shows you sort of the general continuum of any of ours ability to pay attention and regulate our own behavior. And we generally think of ADHD as sort of being in the little box at the end, right? That little box or that bucket is the ADHD bucket. If you have that much difficulty paying attention and regulating your behavior, then you're ADHD. So overdiagnosis happens when we kind of slip, when that box moves, when we get a bigger bucket, we end up putting more kids in that ADHD bucket who maybe in a different time or a different setting or a different place might not have been considered ADHD. And I mean, that's the thing about ADHD. There's no blood test. There's no, there's no real hard and fast line of, what's ADHD versus what's a kid who's just a little more hyper. So that's something that we want to be careful about, is figure out where are we drawing that line, and are we moving that line too far into what otherwise would have been considered kind of typical behavior. So when we think about that's what we don't want, so then we need to define our goal, right? So we don't want overdiagnosis. So we've defined our goal here is children being diagnosed appropriately, with efforts made to avoid overdiagnosis. So, another thing we don't want is we don't want misdiagnosis. That's another reason why we might end up with a kid diagnosed with ADHD for the wrong reason. So misdiagnosis is when we think the behavior that that we're seeing is coming from ADHD, but it's actually coming from something else. And so if we look at this kid, if you see this kid in your practice or at your school, he's acting out. One thing you might think is ADHD. There we go. I figured it out. When, as we all know, little kids, particularly the younger you get, little kids can show the same behavior, and it can be coming from a multitude of different sources, different problems, different disorders. This kid's behavior could be coming from any of a number of different sources. We could have a learning or a language disorder. Doesn't want to sit still, gets really angry, gets really frustrated, looks ADHD. It's actually coming from a learning or language disorder. Could be coming from anxiety. Could be coming from symptoms associated with the autism spectrum. Also could be coming from the effects of trauma or toxic stress, which that's been getting a lot more attention in the behavioral health field and also the healthcare field, is toxic stress, which, as you may know, is the effects of sort of chronic stress on children, particularly without the assistance of a protective adult to help children handle that stress. And some of the effects of toxic stress, sort of inability to regulate emotions and hyperactivity, can't sit still, they look a lot like ADHD. So that's something that we really want to do, is we want to figure out, is it ADHD or is it something else? Because if we look at this kid and we treat him for ADHD, that's not going to help his anxiety. And that's not going to help the trauma or the toxic stress he's experiencing. It's just not going to help him. So in defining our goals, the flip side of that thing we don't want, the thing we do want, is that children's true needs are diagnosed, with efforts made to avoid misdiagnosis and to accurately assess conditions that might look alike or co-occur with ADHD. And we put a lot of emphasis on that because we want to make sure that our kids with other things going on, with other difficulties, with other problems, are getting the help and support they need. Because a Ritalin prescription is not going to help them with those other things. So another thing we don't want, so that was all the diagnosis stuff, the wrong reasons for an ADHD diagnosis. So now to move on with some of the wrong reasons for medication treatment. So we don't want overuse of medication. We don't want medication used when a child should have received a different treatment. Should have received treatment, but a different treatment other than medication, based on the child's age or best practices or the parent preference. So just to kind of briefly review the best practices for ADHD treatment, fortunately, there's broad national consensus on what the best practices are for ADHD treatment. We know what they are, and we've known what they are for a while. The issue is kind of making that happen, and that's something that we're going to talk about a little bit later. So these are the recommendations based on the American Academy of Pediatricians, and these have been adopted by the psychiatrist groups as well. These are broad, everybody agrees on these. Everybody's pretty on board with these recommendations. And they're based on age. So for preschoolers, we're talking about 4 and 5-year-olds, the consensus is that medications are not the first line approach. Medications can work with 4 and 5-year-olds, but they're not what you should try first. The first thing you should try is behavioral treatment, behavioral therapy, which I'll talk about in a minute. And the reason for that is the research. There's very little research on the effects of medication on 4 and 5-year-olds. There's like 1 or 2 studies. And they do show them, and they show the medications to be less effective with kids at that age, and less safe. Whereas we have great research on behavioral therapies. They really work. They really help kids and they help families. And so that's why those behavioral therapies are the preferred treatment for 4 and 5-year-olds. And medication to be used if the behavioral therapy is kind of not getting there, if it's not enough, and the kid really, if that's not working and it's not enough, then yeah, medication can be tried. But it shouldn't be the first line of defense. Now for elementary school age kids, 6 to 11 years old, medication's great. ADHD medication, when it's prescribed for the right reasons, is very effective and very safe. And so the right medication at that age is recommended, along with behavioral therapy, as needed, preferably both. So you can have both or either for those elementary school age kids, and then the same for adolescents. The teenagers, they kind of have to agree. That's the recommendation from the pediatricians, is make sure your teenager signs onto this, because otherwise it may not go as well. And potentially behavioral therapy, preferably both. And just back to those evidence-based behavioral therapies, there's some great ones out there. There's been a lot of, so first of all, we're not talking about individual therapy for a kid. How many of you folks work with little kids in your practice? Excellent. So you all know, you're not gonna sit down and work with that little kid one-on-one and expect that, the things that they've learned with you in session to necessarily translate home. All of these evidence-based behavioral therapies really are working with the child and the parent together. And it's essentially sort of giving the parent the skills and the abilities to work with this child, positive discipline, build a positive relationship, because the kind of behaviors associated with ADHD, they can really tax that parent-child relationship, right? They can cause a lot of frustration and a lot of stress. So making sure to, help that parent and child get back to that positive relationship, and provide some education about the child's needs and typical development, and then helping parents manage those negative behaviors with positive discipline. So it's stuff that you guys do. It's not rocket science. It's a lot of really parent behavioral support. There's some name brand programs that have a lot of solid evidence behind them. So many of which will be familiar to folks, I think. Triple P, the Incredible Years Parenting Program, Parent-Child Interaction Therapy, PCIT. We, by the way, have sort of a local version of PCIT called Parent Management Training that has been, we've had some folks out of Tulane have trained therapists in that approach. There's the New Forest Parenting Program, which is specifically aimed at ADHD. It actually doesn't exist in the US, but it's over in the UK. And then there's some new evidence on a program called Helping the Non-Compliant Child. But these are all the name brand programs, but there's also been an effort understanding that those name brand programs sometimes can be pretty expensive to get trained and certified in. There's been some efforts by a lot of folks, and also the CDC, to promote a components approach, because all of these programs, all these name brand programs, they're all doing the same thing. They're all doing the same thing around promoting positive relationships between parents and kids, promoting education, positive discipline, that sort of thing. So there are ways to sort of pull out the components from these name brand approaches and do them for, with less expense than it takes to train folks in these name brand ones. This is a CDC slide again. The CDC has really pushed out a lot of information recently on this issue of behavioral therapy for preschoolers, because it's one of those things where we can solidly say, we can't look at the rates of medication for older kids and say those rates are too high necessarily. It's a little hard to sort of define what rate would be okay. But for little kids, because we know that behavioral therapy should be first, if we see those kids aren't getting behavioral therapy, then we can kind of say, yeah, those kids are not getting the best practice treatments. And so they've pushed out a lot of data to show that not enough little kids are getting those behavioral therapies first. And we certainly know that that's the case here in Louisiana. We have a lot of work to do to sort of build up our system's ability to provide this service to kids. Okay, back to what we don't want. Another thing we don't want. We don't want, I guess this is sort of piggybacking on what I was just saying. We don't want the underuse. We don't want overuse of medication. We also don't want the underuse of the non-medication strategies. We don't want to rely on medication alone when the youth would benefit from, a behavioral therapy or a different kind of approach. Also, when the youth and family would benefit from good quality care coordination. That's something that a lot of families really hunger for is someone who will help me coordinate all the different pieces of my kid's treatment. I got my school. I got the school counselor. I got the school. I've got the teacher. I've got the doctor who's prescribing the medication. I might have a behavioral therapist. There's a lot of pieces going on, and a lot of times we don't talk to each other. And then parents are the ones trying to coordinate all of that. So there's definitely a best practice for kids with ADHD and a whole host of other behavioral health concerns is to have good quality care coordination, somebody to help that parent put all those pieces together. So that's another reason why we don't want just medication, because then everybody's not talking to each other and connecting. So in defining the goals, all that stuff we don't want, in defining the goals, we want kids with ADHD, once we know that that diagnosis is accurate, it's not a misdiagnosis, it's not an overdiagnosis, if we know that that kid has ADHD, we want them to receive best practice treatment. And that means behavioral therapy, if they're a little kid, also if they're older and they just need it and it will be helpful to them. So it means more behavioral therapy. It means care coordination, so everybody's talking to each other. And it also means follow-up for the doctors. It means follow-up, regular visits to make sure that that medication is staying safe and effective. Sort of a last thing about what we don't want, another sort of reason for overuse of medication really has to do with the environments that we provide to kids. We really don't want to be using medication when the kid is being provided medication in lieu of adults in their environment, providing adequate supports in a developmentally appropriate environment. And that's something we think about a lot. We really want to help and support our parents and our teachers to be able to support kids, even if they're a little hyper, even if they're ADHD, to really help and support parents and teachers to be able to, provide developmentally appropriate environments for kids where they may not need medication to manage that behavior if the environment is supporting them adequately. And some of this has to do with developmental needs for physical activity and play. We know that that's something that a lot of schools have been thinking about recently is, are we allowing kids enough time, enough access to physical activity? Because there's a lot of really good research out there that physical activity helps kids focus. And so that can be a way to, that's developmentally appropriate for kids. So trying to make sure that the environments we provide our kids are really supporting them as well. So our goal is that we want our children to be understood and their development to be supported within their environments, no matter what their level of attention and regulation. Okay, so those are all our goals. So we've talked about all the data, and we've talked about our goals, what we're really looking for in treatment for ADHD. Okay, what next? What are we gonna do now? And so here's where I'm gonna talk to you a little bit about the work that we're planning and preparing for and trying to move towards at the Department of Health with our ADHD task force and in collaboration with a lot of other really important partners. So to take a step back, I want to talk just a little bit about our current system, which I'm sure many of you, if not all of you, are familiar with, our current Medicaid-funded system for behavioral health in the state of Louisiana. So at DHH, we oversee all Medicaid-funded healthcare services in the state, which are now managed by 5 Healthy Louisiana plans. So until like a month ago, they were Bayou Health plans. They're now Healthy Louisiana plans. We've had a name change. So anyway, same plans, different name. So we've got those 5 managed care organizations, the Healthy Louisiana plans, that manage all healthcare services in the state for Medicaid. Now, as of December 1st, 2015, so just about 6 months ago, those plans, each of those 5 plans are integrated. So they used to just do the physical healthcare stuff. And you guys probably know all this already, but they used to do just manage the healthcare services that on the physical health side, and then we had one managed care organization that did all the behavioral health. Everything's now integrated. So if I'm a Medicaid member, I have one managed care organization that's in charge of that's sort of in charge of managing and coordinating all of my healthcare. That means my therapy. That also means my medications. That also means my, if I need surgery, everything is managed by that one plan. And so that provides a lot of opportunities, particularly in this realm of ADHD, because now we have those primary care doctors and those behavioral health specialists all being managed under the same umbrella. And that means that we can now work with so at the Department of Health, we're working collaboratively with all of those 5 Healthy Louisiana plans on a 3-year performance improvement project for ADHD diagnosis and treatment in the state. And they're great partners to work with because they manage all of those services, all of the above that kids need for ADHD. So taking a look at our goals again, these are our goals again. So for each goal, this is sort of what we've been working on in our initiative. We want to look at how can we measure that goal, because as I said before, there's just a high rate of diagnosis. It doesn't really tell us if those are good diagnoses or good medications or not. So we need different things to measure so we can tell that kids are being treated appropriately, getting the help they need, and we also want to be able to tell that our interventions are being successful, right? So for each of these goals, we've defined some measures that we're going to look at, and then we also have some interventions that we're going to start moving towards with the help of those Healthy Louisiana plans. And with the help of folks in that room, folks in this room, which I'm going to pitch here in a minute. So as far as those, making sure that kids are diagnosed appropriately and not over-diagnosed, one thing that we're going to measure and really push for is having our doctors, making sure that our doctors are using standardized tools from parents and teachers to make that diagnosis. So that's one kind of easy thing we can measure. Another thing, obviously, to reduce overdiagnosis, we want to provide more information and more tools to our primary care doctors, to our parents, to our teachers, to really understand where the line is between ADHD versus kind of normal, typical development. So we also want, our next goal is about children being diagnosed appropriately with their, oh, I'm sorry, I said this already. Sorry, before I was talking about the measurements, now we're talking about the interventions. We want to provide support and guidelines to doctors on the use of standardized tools. We also want to provide information and materials and education to doctors and teachers and parents and others in distinguishing between ADHD and normal variation. The reason this is circled is this is something we need your help with. So I'm going to sort of, as we go through these interventions, I really want to highlight the place where behavioral health professionals like yourselves play a really critical role, that we need a lot of help and support from you guys and bringing you guys more into the system of treatment for kids with ADHD, which sometimes, up to now, has really been between the child and the doctor. Well, we need to expand the team, and we need you guys on the team. So our next goal is reducing misdiagnosis, making sure that kids' true needs are diagnosed, that it's not just, I think they've got ADHD, but no, let me dig a little deeper. Let me think about what's going on with this kid and what their real needs are. So some of the things that we want to do to measure progress in this area, to really see if we are diagnosing kids appropriately or if we're misdiagnosing, we're going to look at the ways in which primary care doctors make those diagnoses and look at, are they screening? Are they looking for, are they considering other behavioral health conditions like trauma, like anxiety, like autism spectrum, that sort of thing. We really want to help and support our doctors to look at other options and really help them do more sort of differential diagnosis between ADHD and other stuff. We also want to support our doctors to consult more. We want to measure and look at how often are primary care doctors consulting with a behavioral health specialist like yourselves. How often are they walking down the hall to go talk to the social worker at the end of the hall? How often are they picking up the phone? Do they have a contractual relationship with a consultation service where they can pick up the phone and talk to a social worker or a psychiatrist and say, I have this kid, I'm trying to figure out, is this kid got ADHD? Is there something else going on? Is it all of the above? You know, how often are they doing that consultation? Because we know that our doctors, they've been doing this alone for a while. We don't want them to have to do it alone. We want them to have the support they need to be able to accurately diagnose. So as far as improving care, we want to provide support and guidelines to doctors on how to screen for and diagnose other conditions. That's something that our Healthy Louisiana plans are going to help us with, is really getting this information out there to their contracted providers. But then we also want to increase doctors' access to consultation with behavioral health specialists. And that's something that our Healthy Louisiana plans are looking at ways that they can support that, ways to support having the social worker down the hall in the group pediatric practice, ways that they can support having those, telephone, consult relationships where the doctor can pick up the phone and talk to a psychiatrist. And again, I've circled that because that's a role that yourselves, the behavioral health specialists, can play as well, as being sort of being the social worker down the hall or being, part of those consultation services to help doctors when they're trying to make a tough call. So then we get to our goal of children receiving best practice treatment. So some of the things that we want to measure, to look at, are kids getting best practice treatment? We want to look at how often do preschoolers get behavioral therapy first? That's very important to us, because that's a really solid, real clear measure of, is this kid getting the best practice treatment? Are they getting behavioral therapy first? Right now we know it's probably not happening a whole lot, but we want to start looking at that and start making that better. We also, just across the board, not just little kids, we want to look across the board at how often do kids diagnosed with ADHD get medication or get behavioral therapy, both or neither. And we wanted to sort of monitor those because we want all children. We probably have underuse of behavioral therapy at all age groups. The little kids are the ones where we really know solidly that they need it for sure, but we probably need to see it go up for the other age groups as well. We want to look at how often do kids who are prescribed medication, how often do they get their follow-ups at the recommended time frame, so they're getting checked to make sure that this dose is still working and side effects are okay. And then how often do kids get access to care coordination? How often are kids and parents getting help and support to put all of these pieces together? So these are some of the things that we're going to be able to start measuring so we can see where we're at and then see where we want to go. As far as improving these things, what we're going to do to try to move the needle on some of these measures, we want to educate our primary doctors on prescribing behavioral therapy first. They're pulling out their prescription pad. We want them to know that what they should be looking for those little kids is behavioral therapy. And we want to, where we have local providers of these therapies, we want to make sure that our doctors know about that. And we can help our doctors link and build relationships for those folks who they can refer to. We also know that we don't have enough. We don't have enough therapists who are providing those evidence-based therapies for little kids. We haven't supported that workforce enough in our state. So we want to increase the workforce of therapists trained in evidence-based therapies that work for ADHD. We have an initial, I don't know if anybody in this room was part of an initiative that trained up some providers in child-parent psychotherapy, CPP, which is evidence-based intervention for little kids with trauma exposure. Really helps rebuild that parent-child relationship. And the reason I mentioned that on an ADHD presentation is that we want, if we help our doctors to identify things other than ADHD, we also need to be able to tell them, okay, and then here's what you do. You refer this child and family to a provider who can help them with their trauma needs. So that there was an initiative in the last couple of years to train some providers across the state in child-parent psychotherapy, and then also in parent management training, which I think I mentioned before is kind of a local version of PCIT, which is really a gold standard treatment for all kinds of disruptive behaviors in kids. It works with ADHD and it works with all kinds of other sources of behaviors in kids that are troublesome for parents and teachers. So we have a little bit of that going on, and we definitely need more. We also want to increase the practice of care coordination to children and families with ADHD, and so that's something we're also talking to our Healthy Louisiana plans about, is how can they support a group pediatric practice to have a care coordinator on staff. So you go to your doctor, you get your prescription, then you go to your care coordinator, and she asks you, okay, so who do you need us to be working with? How can we connect with your school? How can we bring all these pieces together so you don't have to be juggling all the pieces on your own? And then this last goal, the children are understood and their development is supported within their environments, no matter what their level of attention and regulation. Under measuring progress, I have please stand by. And that's because this is, some of this stuff is about school environments, which we at the Department of Health don't, that's not under our scope. And at the same time, we have some great partners at the Department of Education where we're really working on, they are really working on, and we're supporting as much as we can, their efforts to help support schools and teachers to provide these kinds of environments that can really understand and support kids no matter what their level of attention and regulation. Some of the things that the Department of Education is working on as far as improving care for kids, they're revamping their system of how they evaluate teachers, and they're trying to include some things in there that really look at teachers, not just their ability to teach math and English, but their ability to support all learners and individualize what they're doing in the classroom for all learners. And the department is going to, I think, is going to specifically define all learners to include gifted, to include, exceptionalities like ADHD, to include, special ed populations. And this, I think this will be helpful in sort of reframing what they want to see teachers do to be a good, solid classroom teacher. And that comes along with also supporting teacher preparation programs to have more of a focus on serving children and kind of all learners. They're working on updating their guidance on evaluation and services for students who fall under Section 504, because a lot of our kids with ADHD, their level of impairment in the classroom doesn't rise to the level of needing an IEP. So a lot of the kids are falling under those 504 plans. And the department has really looked at their guidance to schools on how to develop 504 plans, what kind of accommodations are useful for kids, and really realized that there's a lot more support that can be provided to individual schools and districts and how to do those and how to make those really effective for kids with ADHD. So they're working on that. And then the thing that I'm most excited about, and actually just came from this event yesterday, there's a really interesting partnership going on between the Department of Education and with CHADD, which stands for Children and Adults with ADHD. It's a national advocacy and resource organization for kids and adults with ADHD. And CHADD has developed a lot of really great resources. I'll show you the link at the end, including a curriculum for teachers. They call it their teacher-to-teacher curriculum. And it really helps and supports just general education. We're not talking about special ed teachers, because most of our kids with ADHD are just in the general education classroom. So we really need to support all teachers to understand their needs and help them. So the teacher-to-teacher curriculum takes teachers through some great information and education about ADHD, the brain science about ADHD, given the fact that it can change your relationship with a teacher and as a parent. It can change your relationship to a kid with ADHD once you just understand they're not doing it on purpose. I think that is a common response to kids with ADHD is they're being defiant, they're not listening, they're choosing not to do their work and sit still and be on task. Once you understand the brain science behind it and understand that these kids want to learn, they just can't do it without the help and support, that can change some of the way the environment is structured in the classroom and help teachers be able to provide more support and accommodations. And then also that teacher-to-teacher curriculum offers a lot of help and strategies for teachers about actual strategies, hands-on, that they can use in the classroom to support kids with ADHD. So that partnership has been under development for a little while, and the first big kickoff of that happened in the last few days. That the Department of Ed just hosted their Teacher Leader Summit, where they welcomed teacher leaders from across the state to a big summit in New Orleans. And over the course of 2 sessions on Wednesday and Thursday, the CHADD trainers trained 150 teacher leaders in this curriculum. And those 150 teacher leaders are going out, back to their home districts across the state with some new knowledge about, how to support kids in the classroom with ADHD. And then I was able to attend the session yesterday, which was for supervisors, kind of administrators, principals, district personnel, talking about really trying to tell them about this approach and how this can help their teachers and their schools. And we had some great conversations with folks there about some pilot projects that CHADD is able to help over the next year to put some pilot projects into particular schools or districts to train a cohort of master teachers who can then disseminate this information to teachers across their school and district, and build in support to teachers to use different strategies and really better be able to support kids with ADHD in the classroom. So I just came off of this, I'm pretty excited about it. So, in summary, just as I wrap up, I wanted to just go through the things that you can do for all of the hardworking licensed professionals in this room. There's a lot of different opportunities for you to sort of support in this initiative. So if you're an independent practice or in an agency serving kids, You can certainly take advantage of upcoming trainings in those evidence-based programs for preschoolers with ADHD. We're going to start rolling that out fairly soon, and if anybody's interested, you know, you can email me or write your email down. I can update folks as those trainings come out. If you happen to be in an integrated healthcare setting, or if you're interested in going into an integrated healthcare setting, I think there's going to be more and more opportunities as we really move towards good integrated care. There's going to be more and more opportunities for licensed behavioral professionals to be in those pediatric settings, to be doing therapy just down the hall from the doctor, or providing that consultation or care coordination. I think that's going to be a growing need that can really benefit our kids and families. If you're a professional in a school, there's a lot of opportunities there. You can provide information and consultation to teachers about what you know and resources that are available to you around how to support kids, how to understand ADHD, how to support kids in the classroom. You can also talk to your teacher leaders and your administration about this pilot program that is starting to roll out with the support of CHADD. That you can try to get them interested and engaged in maybe bringing the CHADD program to your school. And that is the end of my presentation. I have some links here for information. We have, what we have here is a picture of our ADHD task force webpage, which does not have some latest information. Give me about a week and I'll get some more information and links up there. Here's my contact email. Anyone who's interested in getting more information about any of the specific things I've noted or ongoing updates, I'd be happy to connect with you. I've also just put a couple useful links. CHADD's National Resource Center on ADHD has a wealth of information, handouts for doctors, teachers, parents. I mean, just a lot of great information on that website that you can look around. And then the last one is the CDC, Centers for Disease Control research page on ADHD. They have a ton of information. I mean, a lot of that data on statewide differences. They also have a lot of great handouts and information on the behavioral therapy piece, that's something that they're really trying to promote. So thanks everybody for bearing with a long, full of data presentation. And I'd be happy to take questions.
Absolutely. I want to thank Dr. Savicki for a wonderful presentation. I think all of us would agree that it's wonderful that this effort is going on now on the ADHD initiative in Louisiana, and there's an important role that we all play in this, and I really appreciated those comments from Dr. Savicki. I would like to hear from you. Any comments, thoughts, questions? I know there's probably many of you that work with kids that have ADHD, or maybe you have a child of your own that has an ADHD diagnosis. So we'd love to hear from you with comments or questions. And I have the microphone, so I'm going to bring them. Actually, there's a microphone over there. So I'm going to let. There's a microphone? Yes. Microphone.
And check it out, guys. I didn't blow out anybody's eardrums. This is like a first for me.
Hello. I had an opportunity to attend the Teacher Leader Summit, but I did not have an opportunity to attend the training because the sessions were closed. Are they going to be bringing the sessions to the individual districts or schools here in Baton Rouge for training?
That's a great question. It's really up to schools and districts to sort of raise their hand and say, I want this to come. Right now, what CHADD is looking for is, sort of 3 or 4 schools or districts that really want to jump on the bandwagon right now and do a pilot program over the next year. The folks in that, I didn't see EBR folks in the supervisor session I was in, but that's certainly something that that you can approach your administration about. I can give you the contact information about who you want to contact to reach out to try to, or you can just email me and I can connect you to the right folks. I know that our local, sorry, one more thing, our local advocate with CHADD here in Louisiana who runs the parent support group, the CHADD parent support group for parents with ADHD, I think she personally contacted Warren Drake to sort of kind of, let him know about this and ask about interest. So, it's, folks here know about it, whether or not they're kind of ready right now to jump on it. I mean, that might have to do with you guys, speaking up. So.
To what extent is their confidence that that 13% figure you showed of prevalence in Louisiana is accurate. Because my guess, based on the behaviors of youngsters and their suspensions and expulsions and enrollment in alternative settings, is much larger on an individual school basis, I mean district basis, than 13. So it would seem it would be bigger than 13% across the state. A lot of the kids are not being diagnosed.
That's absolutely accurate, that there's sort of that, both that underdiagnosis and overdiagnosis, right? So that I think the 13%, remember correctly, that's across the board, right? That's all kids across the state. Individual schools, different populations, different areas have much different percentages. For instance, one of our hotspots for ADHD diagnosis and treatment is in the Lake Charles region, for whatever reason, I don't know why. But in that region, I think we sliced the data to show that don't quote me on this, but I believe it is that of Louisiana, of boys on Medicaid, of 8-year-old boys, no, I'm sorry, of 8-year-old Caucasian boys with Medicaid funding, with Medicaid coverage, 40% are diagnosed with ADHD. So based on the demographic mix and where you are, there can be much higher rates. And we certainly, at that teacher leader conference yesterday, talked to a woman who has an alternative school in Jefferson Parish, and she was saying the rates of ADHD diagnosis in her school are like 80%. So yeah, I think it can vary greatly.
The other comment that I had that I really liked that you pointed out, Dr. Zabicki, is that there are a lot of other diagnoses that are appropriate that have similar behavior patterns. And so there may be an underdiagnosis of some of those disorders that you had mentioned, particularly the toxic stress issues, anxiety, and autism, those kinds of things. So there's a lot of behavioral health issues that are challenging our kids and families, but I don't know about the diagnosis, how accurate that is. And so I do think there's definitely a need. Thank you very much. Anyone else like to make a comment? Thank you all.
Has there been any research done on physiological links to the increase in ADHD diagnosis? Given that ADHD is on the autism spectrum, there's been some discussion on immunizations being a link between, especially Medicaid kids, an increase with, especially Black males, Medicaid kids, with the ingredients in your recent immunizations. Has there been any research on that, the physiological aspect?
I don't believe so. I mean, there certainly is often a correlation between autism spectrum and ADHD, and also there's pretty similar symptoms. So ADHD, some of the kind of brain science behind ADHD says it's executive function deficits, sort of that ability of the executive functioning of the brain to know, okay, I got to pay attention to my teacher instead of the bird flying by. That executive function kind of tells your brain what to do. That's part of the struggle for kids with ADHD, and that certainly is the case for kids on the autism spectrum as well.
But I think there was some misinformation out for a number of years, and maybe Dr. Zabicki can speak to this as well, is that there are certain ingredients in the actual vaccinations that were linked to some of these ADHD diagnoses. And as I recall, I think some of the recent research or research in the last 10 years has refuted that.
Yeah, that science has been pretty well discredited at this point. But
we do want all of our kids to be immunized. That's important. But I know that there was a lot in the news a while back about that. So we want to, reassure parents that the research does refute that connection. Are you all seeing the school environments changing for our kids that have the ADHD? I was just really curious about what you all think, those of you who work in the schools. What do you think about that? Because what we talked about, a lot of our kids, not just the ADHD diagnosed kids, have other learning styles and learning needs. And do you think our environments are changing in the schools that can kind of accommodate that? A lot of kids can't sit still for, 6 hours in a day, What do you think? Working in the school?
We find trauma is starting to be a focus more than it was in the past.
I'm sorry.
That's excellent. We know that a lot of kids are affected by trauma for sure, particularly with some of our natural disasters and other family disability issues, things like that. So, comment over here.
We would like to know, what are you all doing as far as the Spanish population?
As far as the population that speaks Spanish, was that the question?
Yes.
No, no specific interventions for that population. Really, it would be all of our efforts are really across the board, across all Medicaid services, and then the Department of Ed is looking at all kind of statewide approaches to education. So I think just at the local level, those services would be adapted to particular populations, but at the state level, we're not doing anything specific.
I was just curious too, are you finding differences by ethnic groups, like Hispanic versus like Asian versus
Well,
African American?
nationwide, there's very clear demographic differences that white and African American children have higher rates of ADHD diagnosis than Latino children have lower rates. I think we had a hard time getting enough, I mean, because the Hispanic population in the state here is relatively low, and so I think we've had a hard time finding those same, just based on that numbers, finding those same differences here. But given that those are national trends, that probably holds up.
All right, well, that'll wrap up our first session, and we are going to try to put all of the presentation, the slides, on the iCare website. So I just wanted to make sure, because there's some great information that I know you'll want to access later. So we'll be making an effort to put all those on the iCare website. So check back next week for the actual slide presentations. Thank you again, Dr. Savicki. We
Thanks,
really
everyone.
appreciate it. And we have about a 10-minute break, so if you want to run, get something to drink, run for the rest, we'll start again at 10:30 for your second presenter, Dr. Bo Clark.